Hello everyone, my name is Amrjit Dhillon and my topic for the DNP Scholarly Project is Assessing for Depression and Anxiety in Oncology Patients Receiving Chemotherapy. I appreciate the support and guidance from my chair, Dr. Snell, my course faculty member, Dr. Senheinrich, and my community member, Dr. Nwanko. Thank you all for being a part of this journey. In this presentation, I will be covering the following key points of my DNP study, including background significance, review of the literature, theoretical framework, methods design, sample, data analysis, results, limitations, discussion, implications for practice, and conclusion. Two of the most common mental health conditions at my clinic include depression and anxiety, which are among the most prevalent conditions patients are dealing with while undergoing chemotherapy. In our clinic, there is only the PHQ-9 screen tool to assess for depression. However, patients who may have anxiety are not being assessed as there is no screening tool for that. The intent of this scholarly DNP study was to consider implementing a thorough psychosocial screening tool that would identify anxiety and depression in oncology patients receiving chemotherapy. Including the GAD-7 screening tool along with the PHQ-9 would address anxiety and depression. Psychosocial symptoms are often undertreated and overlooked. Grassi ETAL 2023 states that anxiety and depression are among the most prevalent symptoms in oncology patients. Anxiety and depression, if not addressed, can lead to distress, poor quality of life, increased risk for suicide, and increased mortality. When these symptoms are addressed, oncology patients have notably longer lifespan and experience optimal health outcomes. Zhang et al. 2022 states that addressing anxiety and depression can improve quality of life of oncology patients. Psychosocial mental health is a fundamental component of a patient's well-being while receiving chemotherapy treatment. It is crucial to have a psychosocial screening tool that can be used on all cancer patients receiving chemotherapy and addressing anxiety and depression. Psychological interventions such as cognitive behavioral therapy have shown to improve outcomes in managing anxiety or depression in oncology patients. Side effects of chemotherapy can increase the risk for anxiety and depression as well. As a result, these psychosocial issues can lead to decreased quality of life, increased mortality, and interruption of anti-cancer treatment. The general anxiety disorder, also known as GAD-7, and Patient Health Questionnaire 9, PHQ-9, have shown feasibility as practical screening tools for anxiety and depression. The GAD-7 and PHQ-9 scores are crucial as they provide a quantitative measure of the severity of anxiety and depression, guiding the level of intervention required. The impact of this study on practice is that using an evidence-based intervention such as the GAD-7 screening tool for anxiety can improve patient outcomes in oncology patients receiving chemotherapy. In addition to the PHQ-9 screening tool for depression, the GAD-7 screening tool can be used to screen all patients on every visit. The screening tools will benefit and guide providers and clinical staff in determining which resources to provide to patients and in managing their care. If the patient's psychosocial needs are met, they can continue chemotherapy, improve adherence, reduce stress, and have a better outlook on life. Overall, patient satisfaction can improve by meeting their psychosocial needs. Building rapport with patients during their difficult journey can improve the provider-to-patient relationship. The research question includes: in oncology patients, can the implementation of anxiety screening using GAD-7 in conjunction with depression screening using PHQ-9 and the use of support programs during chemotherapy affect their PHQ-9 and GAD-7 scores? According to Rahman et al. 2022, the PHQ-9 questionnaire is a 9-item self-report instrument designed to measure the severity of depressive symptoms over the past 2 weeks. The PHQ-9 has shown to be reliable with Cronbach's alpha 0.8 and McDonald's omega 0.86. Validity was confirmed by a confirmatory factor analysis which yielded a value of 0.879 and was statistically significant. In contrast, Evidence 2022 states that the GAD-7 questionnaire survey includes a 7-item self-report to measure the severity of generalized anxiety disorder. The GAD-7 has been shown to be reliable with Cronbach's alpha 0.91. Tian and Jimenez 2023 report that side effects of chemotherapy can include gastric symptoms, fatigue, and pain, which can escalate anxiety and depression. These psychosocial conditions can aggravate over time and affect patients' quality of life and overall prognosis. If anxiety or depression is not managed or left untreated, this can further result in increased mortality rates and could cause interruptions or delays in cancer treatments. Additionally, Amrjit et al. 2021 mentions that mental health changes such as depression and anxiety often precede a cancer diagnosis. There are times when the stress of treatment and concerns about reoccurrence of the disease can exacerbate side effects. At times, patients are dealing with the fear of cancer returning, which can cause ongoing emotional distress and uncertainty about their future. Decision-making difficulties can occur when patients face treatment choices, especially when they lack a supportive system or adequate information. Lastly, any unmet needs regarding emotional support or information regarding their cancer may affect the patient's ability to endure this difficult journey. These factors highlight the importance of providing a thorough psychosocial care as part of the oncology treatment process. Community et al. 2021 states that individuals diagnosed with cancer tend to deal with many psychosocial health needs that go beyond their physical illness. The patients may not only be dealing with mental and emotional needs, but also at a social or spiritual capacity. Some patients may encounter challenges such as managing treatment side effects, maneuvering through a complex healthcare system, or trying to seek reliable information on their type of cancer. These variables can heighten feelings of anxiety and distress, which can affect the quality of life. Addressing these needs is not only part of treatment, but also a critical component of cancer care. When a healthcare provider recognizes these psychosocial needs, they can lay the foundation for more adequate support. The framework that guided this project was the Plan, Do, Study Act, also known as PDSA. According to Amrjit et al. 2023, the Plan, Do, Study Act framework identifies a process that indicates a problem or improvement needs to be solved. PDSA involves planning, implementing the plan, analyzing the results, and determining whether any changes are needed. The PDSA process enables continual improvement, which is essential for quality improvement in healthcare. Trial and errors are present, which reinforce change, transformation, and advancement. Applying the PDSA framework to the DNP study is helpful in the sense that depression and anxiety are the two main mental health conditions being assessed with the GAD-7 and PHQ-9 screening assessment tools. The plan is to assess for depression and anxiety in oncology patients receiving chemotherapy by proper psychosocial screening with the use of GAD7 and PHQ-9, and offering support programs or interventions to the study participants based on how high their score are. Then once the initial GAD7 and PHQ-9 screening score are retrieved from the 10 to 15 study participants who are to start chemotherapy, these scores would be recorded. Next, depending on the GAD7 scores, if a participant scores 5 or higher, they will be provided with pharmacological interventions, support programs, or resources such as counseling, support groups, and educational materials. Participants who score 10 or higher on the PHQ-9 screening will also receive these resources. After using support programs and interventions, participants will be rescreened with the PHQ-9 and GAD7 to determine whether their scores have decreased. During this time, the results will be analyzed and recorded. This process will allow transformation and any modifications to happen and determine if the GAD7 and PHQ-9 scores have decreased. Were participants given the appropriate resources based on their score? If not, that will allow for improvements to the study and for determining what changes are needed for decreasing the GAD7 and PHQ-9 scores for these participants. The setting of this study was a small community hematology and oncology clinic located in the Midwest. The clinic serves adult patients ages 20 to 90 years with solid tumor cancers and hematologic malignancies. A qualitative retrospective design was used in this study to determine whether implementing the GAD7 and PHQ-9 screening tools, along with support programs, would affect patient scores on these assessment questionnaires. The sample size included 20 participants who were new chemotherapy patients diagnosed with cancer. These participants were identified through a chemotherapy education session presented by the clinic's nurse practitioner between March 23rd and March 25th, 2026. Both female and male participants were identified and recruited during a 1-hour chemotherapy education session. Eligible participants were new start chemotherapy patients, scoring 1 through 21 on the GAD7 or 1 through 27 on the PHQ-9. Routine patients who have already received or completed chemotherapy were excluded. During this time, the patients were given an initial GAD7 and PHQ-9 survey to complete. Once participants were selected during the education session, they were provided with support programs and resources, including counseling, support groups, education materials, and pharmacological medications between March 26th and March 28th of 2026. After these participants completed their first round of chemotherapy and used the provided support programs, they were screened again with the GAD7 and PHQ-9 questionnaires between April 20th and April 23rd of 2026. The pre and post scores of the GAD7 and PHQ-9 were reviewed, compared, and recorded to conclude whether there were any variations. Qualitative data, such as questionnaires, were used to determine whether implementing the GAD7 with the PHQ-9 and support programs would affect patients' scores on these assessments. Data was recorded in a collection sheet in a Word document and later exported to an Excel spreadsheet. The Wilcoxon matched pairs test in SPSS statistics was recommended following consultation with the university statistician. The goal was to determine whether there was a change in the scores on the pre and post questionnaires of the GAD7 and PHQ-9 assessments. A sample size of 42 patients would have been ideal to achieve the desired power and statistical significance. However, at least 10 were needed. The potential risks of this project were minimal and primarily related to breaches of confidentiality during data collection or storage. To minimize risks, the Oncology NP removed all patient identifiers, and each patient received a different letter before data entry. The data collection sheet included only a specific letter for each patient, numerical scores for each questionnaire, and the appropriate intervention. The data was stored on a password-protected computer accessible only to the project author, the Oncology NP. All participants' data were stored on a password-protected computer in a locked office. The scores from the hard copies of the GAD-7 and PHQ-9 questionnaires were recorded in a Word document on a password-protected computer. Then once the scores were documented, the hard copies of the GAD-7 and PHQ-9 questionnaires were shredded immediately. All data was deleted once the project was completed. As this project involved a review of existing de-identified patient charts, informed consent from the study patients was not required. This project adhered to all HIPAA privacy principles and Maryville University DNP requirements. The clinical site had authorized the use of de-identified data from electronic medical records for quality improvement initiatives. Institutional Review Board approval was first obtained from the Maryville University and from the Cancer Care Clinic site where the study was to be implemented. Next, RBR approval was obtained through Maryville University. The DNP study committee had decided that this study includes minimal risk and is not considered human research. Therefore, this study did not require IRB review at Maryville University. No consent forms were required for this study, as no protective health information was documented and the study involved minimal risk. Only retrospective data were collected for this study, and only GAD-7 and PHQ-9 survey scores were noted. On average, patients had lower median GAD-7 scores after the intervention, which were 5, than before, which were 7.94. Likewise, patients had lower median PHQ-9 scores after the intervention, noted to be 8 than before, which was 12. The Wilcoxon test indicated that the GAD-7 scores decreased after the intervention and were statistically significant. So W equaled 163, Z score of negative 3.37, and statistically significant less than 0.001. Similarly, the PHQ-9 scores decreased after the intervention and were statistically significant. So W equaled 185, Z score equals negative 3.37, and statistically significant at less than 0.001. Overall, there is a strong evidence of change in pre to post intervention scores on both the GAD-7 and PHQ-9. In this study, a Wilcoxon-signed rank test was used to determine whether psychosocial interventions would affect the pre-GAD-7 or PHQ-9 scores. The Wilcoxon-signed rank test was chosen to compare the two dependent groups with ordinal measurements. The Wilcoxon-matched pair test was used to determine whether the paired observations differed significantly, but also whether there was a relationship between using a psychosocial intervention depending on the assessment questionnaires from the GAD-7 and PHQ-9 screening, and whether the interventions would decrease these initial screening scores of anxiety or depression for oncology patients receiving chemotherapy. The patient's pre-GAD-7 and PHQ-9 scores were compared before and after the psychosocial intervention, which included support groups, physical therapy, psychiatry, referral, or pharmacological interventions. The study results showed that the post-GAD-7 scores had a mean of 5.15 and a standard deviation of 2.11. The post-test PHQ-9 scores had a mean of 8 and a standard deviation of 2.34. With 95% confidence, the mean GAD-7 scores were between 4.16 and 6.14, and the PHQ-9 scores were between 6.91 and 9.09 after the psychosocial intervention was implemented. The scores indicate that the sample mean has a confidence interval of 1.96. The standard errors calculated for the pre and post GAD-7 and PHQ-9 scores indicated that the ranges do reflect a true population value given a sample size of 20 participants. Table 1 is showing the pre-test GAD-7 and PHQ-9 scores. The blue represents GAD-7 scores and the orange represents PHQ-9 scores. Then table 2 is showing the post-test scores after patients have received the first round of chemotherapy and received the appropriate interventions according to the score of both questionnaires, which is 4 weeks later. There is a decrease in scores that can be seen when comparing these two tables side by side. This table demonstrates that there is a statistical significance noted in pre to post GAD-7 and PHQ-9 scores, less than 0.001. Limitations were noted in the study. It was uncertain whether the intervention used could deliver a desirable result, as the patient group at the clinic site is at times non-compliant. The study was implemented over a 4-week period and could be extended to assess for sustainability. However, once the intervention was implemented, results showed a significant impact on patient outcomes during chemotherapy. The patient's GAD-7 and PHQ-9 scores were compared before and after the psychosocial intervention. The analysis showed that the difference was significant at p less than 0.001. The value showed strong evidence of change from pre to post intervention in both GAD-7 and PHQ-9 scores. In oncology patients, the implementation of anxiety screening using the GAD-7 in conjunction with depression screening using PHQ-9 and the use of support programs during chemotherapy has shown to decrease the PHQ-9 and GAD-7 scores. Implementing a thorough psychosocial screening assessment will impact the patient's healthcare community and practice in multiple ways. Insara 2020 notes a relationship between GAD-7 use and nursing practice. GAD-7 can be used for routine screening or at regular intervals to assess the effectiveness of pharmacological or non-pharmacological interventions. GAD-7 allows us to use this questionnaire in fast-paced settings such as the ER or primary care. The GAD-7 can catch underdiagnosed anxiety disorders in patients, but also can assess treatment adherence in patients. Mental health screening is a universal issue that needs to be addressed and provided to patients of all socioeconomic backgrounds, and it must be easily accessible to patients who speak multiple languages. Ongoing improvement and sustainability of the GAD-7 can include having it integrated into electronic health records, where providers or clinical staff would be required to have patients complete the questionnaire, administer the questionnaire at baseline, and then reevaluate about 2 to 4 weeks for progression, and continuing with staff training yearly. Further research recommendations could include analyzing predictive validity and treatment resistance, determining which characteristics may lead to treatment resistance, such as comorbidities or illness duration, assessing the GAD-7 and comparing across socioeconomic statuses, and implementing the GAD-7 in diverse populations. Further leadership and policy recommendations may include mental health training for all employees, standardizing the GAD-7 in routine or universal screening, and standardizing a referral pathway for GAD-7 scores greater than or equal to 10, with referral to therapy or a mental health specialist for further care management. The impact of this study on practice is that using an evidence-based intervention, such as the GAD-7 screening tool for anxiety can improve patient outcomes in oncology patients receiving chemotherapy. In addition, the PHQ-9 screening tool for depression, the GAD-7 screening tool for anxiety, can be used to screen all patients at every visit. The screening tools allow providers to determine which resource to provide to patients and how to manage their care. Clinical staff, such as nurses or medical assistants, can have patients complete the GAD-7 and PHQ-9 questionnaires, and then providers can determine how to guide care based on patient scores. If the patient's psychosocial needs are met, they can progress with their chemotherapy, improve adherence, reduce stress, and have a better outlook on life. Overall, patient satisfaction can be improved by meeting their psychosocial needs. Building rapport with the patients during their difficult journey can improve the provider-to-patient relationship. The GAD-7 was successfully implemented alongside the PHQ-9 screening tool at the clinical site. The outcome showed an improvement in identifying patients who have anxiety by using an evidence-based, practice-proven tool. The patients who were identified as having depression and anxiety were given proper psychosocial interventions in an effort to decrease their scores on the GAD-7 and PHQ-9 questionnaires. Not only did it try to decrease the score, but it also addressed their anxiety and depression and found solutions on how to manage them. The outcome improved the overall mental health of oncology patients receiving chemotherapy and indicated ways to better manage these conditions. The protocol was shown to be statistically significant in decreasing the GAD-7 and PHQ-9 scores from pre-test to post-test. Even though this study was based on oncology patients, the PHQ-9 and GAD-7 can be used in any setting. Implementing the GAD-7 is cost-effective, as the questionnaire is readily available online for free and can be used during chemotherapy education sessions, which are already 1 hour long, so it does not interfere with the workflow or efficiency of the clinic. This study has potential for sustainability, as it has already been shown to be statistically significant, and the results support implementation. I would like to extend the 4-week time frame. The DNP program has impacted my professional and personal growth in many ways. I have gained a profound understanding of quality improvement initiatives and their implementation in diverse healthcare settings, incorporating evidence-based practice into everyday clinical decisions, and this program has prepared me with advanced skills in the healthcare system leadership and driving outcomes. I appreciate all faculty members who were part of my journey, all advisors, my chair, community members, colleagues, and family. This concludes the end of my presentation. Thank you.